give me the 10,000-foot overview here. What factors do you consider when you start a therapeutic regimen, when you're considering who to put on what?
So there's one important virologic factor, which is resistance.
Okay.
So some people get infected with resistant virus. Based upon the drugs we use, that doesn't necessarily influence our choice of therapy as much today as it had in the past, but it occasionally may. A lot of the factors have to do with the patient. Are they on other medications which could be associated with drug-drug interactions that could influence our choice?
Okay.
Do they have another disease that could influence our choice? Do they have heart disease? Do they have kidney disease? Do they have hepatitis B infection? Do they have hepatitis C infection? Occasionally, the viral load may influence our choice because there are a couple of drugs we may not want to use if the viral load is greater than 100,000. Although it's not my practice to use those drugs. I tend to prefer to use drugs that are as potent and effective irrespective of the viral load or CD4 count. But those have been some factors that influence decisions.
Let's get into a little of the nuts and bolts if we can. Personal approach, initial ART. What's your standard, all comers, what would you choose?
So it's interesting, since the beginning of potent antiretroviral therapy, about 20-ish years ago, in the mid-90s, it was 2 nukes and a third drug. And here we are 20 years later, and it's still, for the most part, 2 nukes and a third drug. I think.
What's the third drug?
So the third drug had traditionally been a protease inhibitor or a non-nucleoside reverse transcriptase inhibitor, and then more recently, with the rollout of integrase inhibitors and more integrase inhibitors, the integrase inhibitors have really taken over as the predominant third drug for most people's first-line regimens.
So how do you select the patients if you're going to do all of these various complicated things? Run through some of these drugs and how you would parse them out.
Yeah, so if you look at the current guidelines, at least in the US guidelines, one of the guidelines panel only recommends integrase-based regimens. And the integrase inhibitors vary a little bit. Some are once a day, some are twice a day. One of them is twice a day. And then the biggest difference is often what they're co-formulated with.
Okay.
Because in addition to the discussion about how easy therapy is and how forgiving it is and how there's little reason to jump through all the hoops we used to, there's also more and more single tablet regimens where we're not just treating people with easy regimens, we're literally giving them 1 pill a day.
Okay.
But they're not all co-formulated with all of the options.
Now, I don't want to get right down in the weeds, and you'll forgive me because I think that what scares a lot of the primary care docs is a list like this.
The list is shrinking. It used to be like,
How about
like
this
two
one?
pages long.
Dolutegravir, abacavir, lamivudine.
All right, go ahead.
All right, there's one. I'm reading these off, and I can barely pronounce them.
That's true.
Dolutegravir, tenofovir, alafenamide, tricidabine.
So if it weren't hard, you wouldn't need us.
Basically, what you're saying is you made this hard, so I couldn't pronounce it, so I'd call you.
Yeah, I mean,
But,
I mean,
look at this menu.
Sure. I mean, to be a little more critical, some of these are better than others.
So tell me what's better and why.
So I think that the best integrase inhibitor is dolutegravir, and I don't think that there's a lot of doubt about that. It's once a day. It's very potent. It has a remarkable resistance barrier, meaning people who fail treatment don't get resistance to it. And you could combine it with any of the nucleosides, including with tenofovir, alafenamide, and tricidabine, which is my personal favorite combination.
So I think Paul's point is that there really are maybe 2 or 3 initial regimens that you would pick from.
Okay.
I mean, dolutegravir, Descovy. The problem with that regimen is it's 2 pills.
Okay.
And some people don't want to take 2 pills.
Okay.
And then there's the dolutegravir, bacavir, lamivudine. That is 1 pill, but not everybody is as happy with a bacavir as they are with TAF or tenofovir alafenamide. So
Okay.
and then finally there's the combination that includes L-vitagravir, which is the third integrase inhibitor. And the issue with that is it's boosted, right? You have to give an inhibitor of P450, and that's not the best thing to give people necessarily.
He's an anesthesiologist.
Oh, he knows.
that.
Right, yeah. We cause a lot of trouble for anesthesiologists with this.
Oh, we
It's
just ignored
all
it.
starting to make sense now, right?
Oh yes, I'm sorting this out as we
Yeah,
speak.
right, sure. But now Paul's going to fix this because Paul, is working on a medication, which we'll get to at the end, that actually has a lot of the advantages of dolutegravir, but it's co-formulated with this tenofovir, alafenamide, and emtricitabine. So we'll get that to the end, but things are even getting better.
But you do understand, somebody looking at a list like
Yes,
this,
totally.
it turns into word salad. after.
Absolutely.
Yeah, but the list used to be a page and a half long. Now, if you read the IAS USA guidelines, which several of us are part of, it's 4 choices,
Okay.
and they're
all
very,
good.
very similar.
They're all good.
And you could throw a dart at them and get it right, pretty much.
But I understand what you're saying. I mean, if someone were to show me for example, the drugs for rheumatoid arthritis, how could we choose that without using them every day? I mean, and that's really what you're talking
Familiarity
about.
breeds
that's right.
expertise.
And there's certainly subtleties.
Okay.
So
Yeah.
while Paul said, this is definitely what I would use, this is my preferred option, there may be certain situations in certain patients where he might not.